Thank you to Dr. Matthew and the Providence team. Let me look at in-hospital glycemic control and to see how modern insulins could actually fit into the treatment paradigm of what we can do to improve the care of patients with and other forms of diabetes in hospital. So the remit is to look at hyperglycemia and look at the burden and the principles of management, look at the next generation basal insulins and how they might help in addressing these challenges, and also look at bolus insulins, the newer bolus insulins, and to see how they may help as well. So that's the remit for this talk. We all know that hyperglycemia in hospital has been defined as any blood glucose that is greater than 140 milligrams per deciliter. This could include lots of things. It could include pre-existing diabetes. It could include stress hyperglycemia. It could include somebody who has not known that they have diabetes and is being picked up for the first time. So there's a big basket of people who could present with hyperglycemia when they come in for an unrelated hospital admission. The links between hyperglycemia and poor hospital outcomes are very insidious and very complicated, but essentially there's a whole interplay of factors, immune dysfunction, oxidative stress, endothelial dysfunction, cellular injury, lots of things that can actually play into why somebody has a raised blood glucose. And there's no dearth of studies which have shown that a high blood glucose is a very strong association with poor hospital outcomes. So if you look at the Indian scenario, the Indian scenario is no different. We do have about 30 to 40% of our patients who get admitted to the hospital at any period of time having hyperglycemia or having a diagnosis of diabetes. We all know that poor glycemic control is always a marker, an indicator of poor hospital outcomes, both morbidity and mortality. And in that sense, I think the data world over is very consistent in terms of giving us this message. I will spend a very short period of time looking at critically ill patients. If somebody is critically ill, the cutoff for trying to decide whether you want to initiate insulin is around 180 milligrams per deciliter. And we have evolved to kind of thinking now, the current thinking being that about 140 to 180 milligrams is appropriate in critically ill patients. There could be specific scenarios like cardiac surgery, post-stroke, etc., where a much more tighter control has more evidence base. But other than that, we tend to aim for a blood glucose reading between 140 to 180 milligrams per deciliter. And usually IV insulin is what is always used. I just highlight this study in this context, this was a study which looked at giving a small dose of glargine within 12 hours of an IV insulin drip and looking to see whether this helps rebound hyperglycemia, stopping rebound hyperglycemia once the IV drip is actually discontinued. And the results are very encouraging. That in the intervention group, only about 33% of patients actually had a rebound hyperglycemia defined as a blood glucose of greater than 180 milligrams per deciliter. Take home point, when you put somebody on an IV insulin drip, you could potentially give a small dose of glargine of 0.25 units per kilogram on top of the IV insulin infusion. This then makes it very easy to stop the IV insulin infusion and prevents rebound hyperglycemia when you do that. Coming to non-critically ill patients, the general guideline is that pre-meal targets are around less than 140 milligrams per deciliter and have a random blood glucose at any time of less than 180 milligrams per deciliter. And so, the two key numbers to remember in hospitalized patients is 140 milligrams and 180 milligrams. And historically, we've always gone for this sliding scale, which is discouraged. It really doesn't treat what we intend to treat. And the current recommendation is not to use sliding scales in hospitalized patients and to use basal plus correctional doses of insulin. And the reasons are very simple and easy for you to see in this caricature. It's not an evidence-based system. When you use a short-acting sliding scale, it's a kind of a reactive approach, and it's not really individualized for the patients. The seminal study in this, and in fact, I think still the only RCT in this, is the Rabbit2 study comparing basal bolus insulin therapy in hospital with sliding scale insulin. So everybody, who came in with a blood glucose, which was deemed to be on the higher side, was randomized to get either a sliding scale or a basal bolus insulin. 50% of them got a basal bolus insulin strategy with glargine and glucine. And you can see here very clearly that basal bolus insulin therapy was superior to a sliding scale in terms of achieving glycemic control. Almost 2/3 of patients on a basal bolus insulin therapy actually achieved a blood glucose of less than 140, as opposed to just 1/3 of patients on sliding scale insulin therapy. So options for basal insulin, we have NPH, we have detamir, we have the 2 strengths of glargine, and we have degludec. And if you're looking at prandial insulins, you can go all the way from regular insulins to the relatively older clids on the block, aspart, lispro, glucine, and you have the faster acting aspart. So if we now turn our focus to basal insulins and what we know about them, obviously the new kid on the blocks being degludec, showing a flatter, any incrementally flatter profile compared to the older basal insulins, twice as long half-life of degludec compared to insulin glargine U100, reaches a clinically steady state in about 2 to 3 days. And you can see the last slide on the bottom right, essentially showing comparisons with glargine and U100 and U300, showing that perhaps degludec does offer some advantages in terms of less glycemic variability as compared to the older basal insulins. Key things in treating patients with inpatient hyperglycemia in hospital: you want to minimize the risk of hypoglycemia, you want to minimize glycemic variability so that you can give better predictability to an unpredictable kind of situation. With degludec, you have some observational evidence that it's fairly effective in hospitalized patients with diabetes in terms of its ability to get good glycemic control. So you can see the slides here, which essentially document what the observational study showed. And in terms of looking at hypoglycemia in hospitalized patients with degludec, it has very low risk of hypoglycemia, even in high-risk patients. Say, even if the patient were to be greater than 75 years, 30 to 35% of those patients looked up in this observational study had CKD. So you can actually get good glycemic control by minimize the risk of hypoglycemia by using the newer basal insulins. I'm fully cognizant of the fact that we are talking about incremental advances, but that's how modern medicine is, that you have incremental advances over what you're actually doing. If you look at the evidence in terms of the PK properties, you can see that you have fairly flat profiles in pediatrics and when renal function is compromised, when hepatic function is compromised, and also in the elderly age groups. If you look at head-to-head comparisons between U300, glargine, and degludec, this is obviously not in hospitalized patients. This is in insulin-naive patients. My take from this study is that there are more similarities than differences between these two, and they're very comparable in how they affect the SMBG scales, fasting plasma glucoses, HbA1cs, etc. The only real difference is that during the initial run-in titration phase, which was, the whole study was around 24 weeks, the initial titration phase was about 0 to 11 weeks. And in the initial titration phase, anytime hypoglycemia was noted to be slightly less in the U300 glargine group as compared to the degludec group, but across the whole study, it was actually comparable. My take from the study is that these insulins are fairly comparable and there's more similarities than any differences. If you look at bolus insulins in terms of inpatient management and see what are the newer options for this, you can see that the big challenge that we have is that 84% of patients do not actually receive their insulin at the appropriate dose. This could be because the nurse is stressed on the ward. There are major other emergencies happening on the ward. So we always want to have insulins which are flexible in terms of how you can give it. If you look at the older kids on the block, there's pharmacokinetic and pharmacodynamic data that perhaps glucine is slightly different from the other insulins. Again, we don't know whether this actually translates into any clinical meaningful outcomes. I'm just presenting PK and PD data here. That glucine, being a zinc-free insulin, has a slightly early metabolic effect and an early onset of action as compared to other agents like aspart and lispro. This is in healthy volunteers. And if you look at what happens in type 2 diabetes, when they were head-to-head compared, again, there was this suggestion that in the first 1 hour after an injection, glycine seems to be absorbed quicker than the other insulin. Again, over the whole period of this study, there was no difference. We do not know whether it actually changes into any meaningful outcomes, but essentially there are subtle differences between these insulins. If you look at the evidence base for aspart compared here with human insulin, obviously better glycemic control, lower hospital mortality, shorter length of stay, and the shorter length of stay essentially means lower costs. If you look at minor hypoglycemia and major hypoglycemia here, you can see that they are substantially less for the analog insulins as compared to the regular insulins. And I think that is where the great advantage lies in terms of minimizing hypoglycemia, because it's always challenging to give the insulin half an hour before a meal for all the patients who are on the ward, for 3 or 4 nurses who are around there. So nocturnal hypoglycemia, I think there is no doubt that the insulin analogs offer a significant advantage in how we can address hyperglycemia, treatment of hyperglycemia safely. 24% reduced lower rate of nocturnal hypoglycemia as well with insulin aspart compared to regular insulin. So aspart also has some reasonable evidence base as to how we can use its profile. Obviously, this is what we are trying to do, trying to mimic what the normal pancreas would do, and trying to see where we are at. So this was where we were at many years ago. And then we had the more rapid acting insulin analogs. We are trying to shift the curve to the left and try to make it overlap what a normal pancreas would do. Obviously, we have still challenges ahead, but I think we have made some incremental steps in having ultra fast acting insulin as well. So this has a much more physiological kind of reaction as to how it works. And the reason for that is that it has niacinamide as part of the molecule, which then allows quicker formation of monomers, and these monomers then get quickly absorbed into the bloodstream. So there are advantages to the faster acting aspart. That can be explained physiologically. If you look at how that actually translates into action, you can see here that the onset of action is ahead of what you would get with the normal aspart. So it's twice as fast in terms of appearance in the bloodstream, and a greater than 74% glucose lowering effect within the first 30 minutes. In my previous talk yesterday, I had alluded to the mounting evidence that probably postprandial hyperglycemia within the first 1 hour does have some significant independent effects in terms of oxidative stress, endothelial dysfunction, poor outcomes, etc. So therefore, having an insulin which is having a faster action might be appropriate in the appropriate settings. So if you compare the newer kid on the block, then obviously it has quick action, 2-fold higher insulin exposure within the first 30 minutes, and a greater than 74% glucose insulin action within the first 30 minutes. So we looked initially at the bolus insulins, and we now have looked at the basal insulins as well. And in both these areas, we can use the power of the newer insulins, and we can unleash the power of newer insulins to get better benefits for our patients. So if you look at what is addressed by the ultra fast acting insulins, think about a patient who has who's not sure whether they're going to eat, who has nausea, vomiting. There's a high risk of hypoglycemia if you give the insulin 30 minutes before and the patient's not able to eat. Whereas with the faster acting insulins, the same you can get the flexibility of giving it a couple of minutes before the patient's going to eat, to even 20 minutes after the patient's actually eaten. Glycine has very similar effects to how you can use it in this kind of scenario. If you look at patients with CKD, hepatic impairment, pregnant women, again, these are people who have a high risk of hypoglycemia, the faster acting aspart has evidence base in terms of safe use in this kind of scenario, and it's approved for use in pregnancy as well. Certainly for nurses, it can be a boon because they have a much greater flexibility in when they can administer the insulin, and they don't need to be timing it appropriate to the meals. Sometimes the trolley doesn't come on time. Sometimes the nurse is held up somewhere. Sometimes the patient doesn't eat, or the patient's nauseous, or the patient goes off food, etc., etc. So there's lots of complications that could happen on a ward where using these kind of insulins can be extremely useful. So I think key messages for me in terms of this talk is to emphasize that glycemic control is very imperative to reduce mortality and severity of complications in patients with diabetes. In anybody who presents with new onset diabetes, hyperglycemia, their morbidity and mortality is raised about 18 times compared to somebody with normal glycemia. So clearly this is something that we need to address. Insulin is obviously the ideal choice for inpatient hyperglycemia management. Glycemic targets necessarily should be individualized for the patients, but remember, ballpark figures of 140 milligrams per deciliter pre-meals and 180 milligrams through the rest of the day. Basal bolus therapy is the most scientific approach in this setting. A sliding scale approach is strictly discouraged and is not physiological, and neither is it appropriate. We have both observational data and RCT data for this. And for better overall control, newer basal and bolus insulins provide incremental superior efficacy with safety. Thank you very much.